Welcome to this keynote lecture on hybrid atrial fibrillation ablation for the annals of cardiothoracic surgery. My name is Bart Maassen. I'm a cardiothoracic surgeon at Maastricht University Medical Center in the Netherlands, and my focus is on arrhythmia surgery. On behalf of my co-authors, I will present this keynote lecture. To fully understand the rationale behind hybrid AF ablation, we need to dive into the pathophysiology of AFib. Several pathogenic factors lead to three remodeling processes that are important for atrial fibrillation. First of all, there is electrical remodeling, leading to a shortening of action potential duration and refractory period, and thereby facilitating rapid conduction. Secondly, there is functional remodeling due to the degradation of contractile proteins, and this increases the thromboembolic risk. These two first remodeling processes occur relatively fast and are to a certain extent reversible. During structural remodeling, structural changes occur to the atrial architecture, leading to uncoupling. These three remodeling processes lead to further stabilization of atrial fibrillation, and of course, several risk factors for AF are known that make patients susceptible for this process. AF progresses over time. During paroxysmal AFib, it is generally believed that there is a hierarchical form of atrial fibrillation, in which one trigger initiates paroxysms of atrial fibrillation that then spontaneously cardiovert. Such a trigger can be an ectopic focus or micro-reentry. With the progression to more persistent forms of AFib, it is believed that the substrate is taking over, and during persistent AF, the substrate is driving atrial fibrillation. And this creates a more anarchical organization of atrial fibrillation. A nice example of such a trigger are the myocardial sleeves of the pulmonary veins. And in 1998, Hassagere demonstrated in his seminal paper for the first time ectopic activation from the pulmonary veins. A nice example of structural remodeling is the occurrence of endomysial fibrosis. Here you see three histological slides of a patient in acute AFib, paroxysmal AFib, and persistent AFib. And as you can appreciate from the slices, there is an increasing amount of connective tissue in between the muscle bundles. And as we could demonstrate, this goes hand in hand with an increasing AF complexity. During mapping in patients undergoing cardiac surgery, we were able to further study this activation pattern of atrial fibrillation. Here you see acutely induced AF in a patient that never had AF before. As you can appreciate, the conduction pattern is not complex, and there are broad ways that almost activate the complete mapping array in one time. The opposite is true in patients with long-standing persistent AF. As you can appreciate, the conduction pattern is much more complex, with waves often as small as one electrode, sometimes waves appearing de novo in the middle of the mapping area due to transmural conduction, and there is a lot of longitudinal conduction block. So atrial fibrillation is a very complex arrhythmia, and it is very difficult to design a patient-tailored or patient-individualized therapy because there is a lack of knowledge and a lack of uniformity of the electropathophysiological mechanisms underlying atrial fibrillation. And to date, we have two big approaches to treat this arrhythmia: the catheter or the surgical approach. Catheter ablation is very successful in the treatment of patients with paroxysmal AFib, but far less in patients with persistent AFib. These are results of the STAR-AF2 trial, randomizing patients with persistent AF between pulmonary vein isolation alone, pulmonary vein isolation plus ablation of complex fractionated atrial electrograms, and pulmonary vein isolation in combination with linear lesions. And as you can appreciate from this Kaplan-Meier curve, there is no difference in outcome between the three strategies, and the results at 18 months are quite disappointing. More recently, the Kaplan trial was presented, And in the CAPLA trial, patients were randomized with PVI alone or PVI in combination with posterior wall isolation. And also here, there was no difference between the two groups. Does that now mean that we should not isolate the posterior wall? On the contrary, because the posterior wall is a very interesting region with all these different muscle layers that are overlapping each other and are oriented in different directions. So in combination with structural remodeling, this seems like a very arrhythmogenic region. And also mapping studies of Robert Thompson already showed the discontinuity in conduction in this area. Why is it then that this isolation of the posterior wall does not result in a higher success rate in the catheter studies? Well, catheter ablation uses unipolar, uniparietal radiofrequent energy, while in surgery we have the advantage that we can use bipolar, biparietal radiofrequency clamps. And as you can see in this animal study, in the bipolar group, transmurality is almost always reached, while this is much poorer in the unipolar group. And also in an in vitro analysis we did in Maastricht, only in the biparietal bipolar group, we were able to show a transmural lesion from the endocardium to the epicardium. In the surgical group, of course, the procedure started with the introduction of the Cox-Maze procedure by the godfather of arrhythmia surgery, James Cox, in the 90s. Since the introduction of the Cox-Maze procedure, there has been a quest for more minimally invasive procedures. And in 2005, Randy Wolf introduced the video-assisted bilateral PVI with a bipolar radiofrequency clamp. This technique was further optimized in 2008 by Yilmaz and colleagues to a complete thoracoscopic approach. In 2012, the hybrid approach was introduced, and in 2020, two unilateral thoracoscopic approaches were introduced, one from the left side and the other from the right side. The concept of hybrid AF ablation is combining an epicardial mostly thoracoscopic approach with an endocardial approach. The thoracoscopic approach allows you to attack the atrial substrate from the epicardium, while transvenous endocardial high-density mapping allows you to visualize the underlying substrate, test the epicardial lesions for conduction block and do touch-up if needed, but also address other arrhythmias like atrial tachycardia or flutter. As said before, the strength of the hybrid AF ablation is that it combines the advantages of an epicardial and an endocardial approach. Of course, thoracoscopic surgery allows direct visualization of anatomy. And even in regions when there is a lot of fat, you are able to dissect the fat away. Because we open the pericardium, there is a low risk of phrenic nerve injury during potential endocardial ablation. And the left atrial appendage is not only excluded, but also isolated. And the advantage is that triggers coming from the left atrial appendage are isolated as well. And if you have a large left atrial appendage, your total atrial mass is reduced. If you do antral pulmonary vein isolation, you can also isolate the ligament of Marshall. And as said before, the big advantage of a surgical approach is the bipolar biparietal radiofrequency clamp. The endocardial approach, on the other hand, can use three-dimensional high-density mapping systems. And this allows us to acquire hard electrophysiological endpoints. You also can do, based on the map, lesion completion from the endocardium, and you can address other arrhythmias like atrial tachycardia or atrial flutter. The hybrid ablation can be performed in 2 stages or in 1 stage. In the 2-staged, first the epicardial procedure is performed and 3 months later the endocardial procedure is performed. Of course, this is logistically easier. You can validate your epicardial lesions after the 3-month blanking period. You don't need a hybrid operation room, and in some countries the 2 procedures can be reimbursed separately. We in Maastricht, we perform the single-staged, and we favorize this because it's an all-in-one approach. It allows close cooperation between the surgeon and the electrophysiologist. If there are atrial tachyarrhythmias that occur during the procedure, you can map and treat them at once. You have an ensured endocardial procedure and potential lower complication rate. This is a slide showing the advantage of a hybrid approach. Here you see on the left side an epicardial isolation for the superior caval vein using a bipolar biparietal irrigated radiofrequency clamp. On the upper figure or movie, you see that next to the pulmonary veins and the box, also the superior caval vein is isolated. And below, you see that if you put a pentaray catheter into the superior caval vein, you can see dissociated activity in the vein dissociated from the normal sinus rhythm. This proves both entrance and exit block. Now there are several ablation approaches for the epicardial part, and I will discuss 3 of them which we use regularly in Maastricht. First of all, you have the bilateral approach. This is a 3-port axis on the right side and a 3-port axis on the left side. In this case, we often use a bipolar biparietal irrigated radiofrequency clamp with glides in the oblique sinus and the transverse sinus that allows us to safely position the clamp over the veins and a part of the box from both sides. The resulting lesion is one continuous lesion that encircles both the box, the ligament of Marshall, and the foreveins. As you are coming from the right, you are also able to isolate the superior caval vein. The left-sided unilateral approach is a 3-port axis from the left side, where we use bipolar radiofrequency clamps with dry radiofrequency energy, and we do an antral isolation of the left side and the right side, and we use a bipolar uniparietal radiofrequency device to create a roof and a floor line. And in patients which are not suitable for a thoracoscopic approach, we can always do a subsiphrid approach, the so-called conversion procedure, where you use a linear device, unipolar and uniparietal, to create lesions parallel to each other to isolate the posterior wall. The disadvantage of this technique is that additional pulmonary vein isolation from the endocardium is needed, and that often also the roofline needs to be addressed from the inside, as the epicardial linear device is limited by the pericardial reflection. This is a scheme of the atrium that allows you to show the different lesions that can be performed with a hybrid AF ablation. First of all, we believe it is of paramount importance to isolate the box together with the 4 veins and the ligament of Marshall. When using a bilateral approach, you can also isolate the superior caval vein. And when you are doing patients that have had several catheter ablations or paroxysmal AFib, it might be of importance to also isolate the superior caval vein. Then we exclude and electrically isolate the left atrial appendage. From the endocardium, we can create a mitral isthmus line or a cavo-tricuspid isthmus line and address other atrial arrhythmias. This is the scheme that we use in Maastricht, the so-called Maastricht approach. When a patient with AF is referred to us, we first look at the type of AF, and in paroxysmal AF patients, we often go for a bilateral approach where we do a PVI, a box, and the superior caval vein using a bipolar biparietal irrigated RF clamp, and of course, exclusion of the left atrial appendage. In persistent AF patients, there are 2 options, or a bilateral or a unilateral approach. And factors that favor a bilateral approach are a poor left ventricular ejection fraction and a wide thorax, where you anticipate that you will not be able to isolate the right veins from the left side. If you have a poor lung function or a hostile right thorax, this favorizes a unilateral left-sided approach, where we do a PVI, a box, and a left atrial appendage occlusion. In patients with a hostile left thorax, we can always do a right-sided PVI and a roof and an inferior line and exclusion of the left atrial appendage. And in patients that are frail and unsuitable for a thoracoscopic approach, we can always offer them the conversion procedure. During the endocardial part, if the patient presents with an atrial tachyarrhythmia that occurred during the procedure, we can map the type of atrial tachyarrhythmia and do additional ablation. If the patient is coming in AFib after the epicardial procedure, we cardiovert to sinus rhythm and we do a voltage map plus validation of the epicardial lesions and touch-up if needed. Patients presenting with a perimitral flutter, we can perform a mitral isthmus line and if needed, do epicardial completion of this endocardial created mitral isthmus line over the coronary sinus. If patients present with atrial tach, we do ablation of this tachycardia. In patients with typical flutter or right atrial dilatation, we perform a CTI line. And if there are organized low voltage zones, we do substrate modification. In patients where we only do a right-sided PVI, roof and inferior line of patients with a conversion procedure, we always need to do endocardial PVI to complete the box lesion set. A particular group of patients are patients with significant left anterior descending artery stenosis eligible for mid-cap surgery that present with AFib. In general, we will do a unilateral left-sided PVI plus box plus left atrial appendage isolation and a mid-cap procedure. If they have very recent paroxysmal AFib and did not have any ablation before, we sometimes limit the lesion set to PVI plus clip alone. And because these patients undergo both a thoracoscopic AF ablation and the mid-cap, we choose to do the endocardial validation procedure in a staged fashion, so after 3 to 6 months. The first report on the efficacy of hybrid AF ablation was reported by Laurent Pizon in 2012, and the results in 26 patients were very encouraging. These encouraging results were then confirmed in our 3 years data, with at 3 years about 80% with paroxysmal AF and non-paroxysmal AF being free from any ADA of antiarrhythmic drugs use. In 2019, we did a large meta-analysis comparing hybrids versus catheter ablation in persistent AF patients, with the primary endpoint being freedom of atrial tachyarrhythmias at 12 months without use of AAD. And in this meta-analysis, we found that hybrid ablation is more efficacious than catheter ablation for the treatment. Here you see an overview of all meta-analyses analyzing hybrid AF ablation. And as you can appreciate, overall, the success rate is between 70 and 75%. An interesting meta-analysis is the one showing up in red, where there is a distinction or a separation between the thoracoscopic hybrid AF ablation and the subxiphoid hybrid AF ablation, so-called conversion procedure, and you see that the results for the thoracoscopic approach are higher than the subxiphoid approach. To study the efficacy of hybrid AF ablation in real-world data, we did a sub-analysis where we included only studies that reported on consecutive patients undergoing hybrid AF ablation, and we created a new Kaplan-Meier curve of these studies, and this shows that 72% at 3 years was free from any ATA allowing AAD and 60% of AAD. Important in this analysis is that the overall complication rate was very low. There are 3 randomized controlled trials that study the efficacy of hybrid AF ablation compared to catheter ablation. The first is the CONVERGE trial. In the CONVERGE trial, 153 patients were randomized in a 2-to-1 fashion between a hybrid convergent arm and an endocardial catheter ablation arm. And as you can appreciate from this Kaplan-Meier curve, at 12 months, without use of antiarrhythmic drugs, the conversion procedure was much more effective than endocardial catheter ablation. But if we compare the results of the conversion procedure with the reported success rates of a thoracoscopic hybrid AF ablation approach, we see that they are lower than the thoracoscopic ones. In Maastricht, we designed the HardCap AF trial, and that was based on the fact that ablation results in persistent AF patients were suboptimal for catheter ablation, and that, as said before, hybrid ablation has the potential to combine the best of two worlds. And therefore, we hypothesize that hybrid ablation is more effective than repeated transvenous endocardial catheter ablation, but almost even important without increasing the number of associated major adverse events. After 12 months, we saw a significant difference between hybrid AF ablation group in red and the catheter group in blue without the use of antiarrhythmic drugs. This significant difference even increased when allowing AAD. And very important, there was no difference in complication rate between the hybrid group and the catheter group. The last randomized controlled trial comparing the efficacy of a hybrid AF ablation with catheter ablation in persistent AF patients is a CEASE AF trial that was recently published. In this trial, over 150 patients were randomized in a 2-to-1 fashion between hybrid AF ablation and catheter ablation. And as you can appreciate from the bar graph, there was a separation between the persistent and the long-standing persistent AF group. In the persistent AF group, more than 70% of patients were free from any atrial tachyarrhythmia, compared to a little bit over 40% patients in the catheter arm. In the long-standing persistent AF group, this was almost 67% in the hybrid arm, compared to 25% in the catheter arm. So given the consistent good efficacy outcomes and the reliable safety profile of this procedure when performed in experienced centers, we believe that in ablation-naive patients with persistent forms of AFib, this procedure should be considered and discussed with our patients as an alternative to percutaneous procedures. Because after all, it is the patient that needs to undergo the therapy and not the physician.